Okay, so moving on, when we look at our x-rays, we know that there are certain things that we should always be looking for. And the heart obviously should show up on the film, no matter whether they did a film with a poor technique or not, you should still be able to see the heart. And of course, we're looking at lungs overall as far as, is there air in the lungs or is there too much air in the lungs? Do you even see your lung markings? Do you see everything that you're supposed to see? Now, anytime that there's atelectasis on an x-ray, then we will sometimes not be able to see that really sharp distinction between like the lung segment and the heart. So as they're saying here, normally it should be a pretty evident border that you could see that the heart would make with the lung. But then in some cases, like in atelectasis or pneumonia, everything may start to kind of get blurred. And this blurring is what they'll call a silhouette, or the silhouette sign. So like take this example here. We've got right lower lobe pneumonia versus the right middle lobe pneumonia. So looking at the image on the left here, there's something going on here. As we can see, it's kind of like infiltrate, something white-ish is showing up here. And you could still see the edge of the heart. So here's the right atrium, and then this would be the right ventricle down here. Well, all this is right ventricle because the heart is rotated to the left. So all this is right ventricle, and then on that side would be the left ventricle and the left atrium. But this will leave you to suspect that there is possibly a pneumonia, and it's in the right lower lobe. And then take the example of the right middle lobe pneumonia here. So once again, we see that there is something out here that shouldn't be there. So there's infiltrates, and it's probably pneumonia. But now, where's the border of the heart? Where's the right border? You can't really see it at all. They end up getting kind of blurred together. So that's that silhouette that was being referenced on the previous slide. So it's classic. How do you know where the pneumonia is? Is it really in the right lower lobe, or is it really more in the right middle lobe area? You look at your heart to kind of help guide you on that. Now, I remember clear to this day, I was sitting with a student in the cafeteria at his hospital. So I was doing a clinical visit, and I brought in some x-rays to help because he was having problems with x-rays. He was like, can you bring some examples of x-rays and we can maybe review on his downtime? Well, it really wasn't downtime. Anytime we go visit a student, then they usually get excused. Like you can go with your clinical instructor and meet with them, and then after that you can come back and catch up with us. So here we are sitting down in the cafeteria. It was like not lunchtime, it was like sometime after lunch, so it wasn't too many people in the cafeteria. And then I pulled out an x-ray of right middle lobe pneumonia. And then I don't know which department this physician worked in, but a physician just happens to walk by and he sees that we're looking at x-rays. And he was like, whoa, that's a really good x-ray of right middle lobe pneumonia. And so before I even had a chance to even question the student, he already gave the answer. And then, of course, after the fact, we had to kind of go back to this. If you can't really see the right border of the heart, then it's got to be in the right middle lobe. Okay, and then while we have these images here, they came out pretty decent. Hopefully you can see here is the right main bronchus, and there's the left main bronchus. So there's our carina right there. And the carina is usually for most patients. I mean, I don't want to keep going back and forth between like adult versus like kids. But in most cases, you will see the carina if the image was done correctly, if the X-ray came out really, really nicely. And then there's the aortic notch, or knob, as some people will call it. And then we compare it to this here. I have to squint, but I could see what looks to be the right main bronchus, and then there's the left. And then we can still see the aortic knob or notch pretty clear on that one. This looks to be overexposed. In addition to me, it picked up the pneumonia without a problem, but just looking at how really dark the lung fields look, this isn't like two pneumothoraces that we're experiencing here. This is the case where the person who did this film probably didn't have the settings completely accurate, and the film ended up becoming overexposed. So it looks almost like burned. I guess you can think of it that way. And underexposed, you know, everything would just look too white. Now, you notice these little images or these little letters here, like R. This is for a reference point. They have to place something on the film that'll show up that will give you direction to say this is the patient's right side, which means this has to be his left side. And then if they didn't write, or they didn't put a little symbol that would say AP or something of that nature, then we would have to just assume that this was a PA film. But a lot of times with these sample pictures that I find, things get cut off. So it may be up there somewhere written that this is an AP film, or maybe on this side. But if you had a real X-ray that you were looking at, you can, with the PACS system, everything digital, you can manipulate that image and move it around as you need to kind of like get a better view of everything. So in other words, it's like cropped out right now, but then you could readjust and resize the image as you need to zoom in, zoom out, and that sort of thing. And then before we go any further, not only is this a right middle lobe pneumonia, but there looks to be something going on this side as well. So this is probably a case of maybe bilateral pneumonia that this particular patient has developed. So then when we look at our pulmonary bronchi, of course, right main stem is what I was trying to do on the other images, are right bronchus, left bronchus, arteries like that pulmonary, like the actual aortic notch or aortic knob or aortic arch or whatever you want to call it, that should show up pretty clearly. And then as far as all of this wispy looking stuff out here, all these little streaky little things, that's normal. That's like all of your lymph vessels, that's your other your veins, your pulmonary veins, everything that's supposed to be there in your hilar area will show up like little, almost like spider web, kind of like. But if this looks to be kind of bigger, like it looks like instead of just little wispy little lines, it starts to look kind of really big, thick lines, or big nodules starts to show up out here, then that could mean that you've got an overactive immunity system and your lymphatic system is very, very active. And they would call that lymphadenopathy. So enlarged lymph nodes in this section here, in this region, which doesn't show up on this film, of course, but we'll look at an example of lymphadenopathy in the next course. When we start talking about the interstitial lung diseases, then I'll have an X-ray that will show a pretty good representation of the lymphadenopathy. And then your aortic arch definitely should be seen. If you can't see it, then again, you have to question the quality of the film. Like, was this film overexposed, or was it underexposed, or is there something else going on? Oh, I do have a film here that shows lymphadenopathy. So here we go. The arrows are just kind of pointing to all this like engorgement that's going on out there when really should just be little streaky lines. So once again, if I stand back, well, if I stand at this angle, I can kind of make out, there's the trachea. I can kind of make out this is the right bronchus here. I think that's the left. And then on this one, it's really hard to see, but I think this is the carina here. But neither one of these examples show anything in the trachea. So meaning that this is not a patient who's intubated, or this is not a patient who's trach, because there's nothing in this region here at all that's showing up, except for the dark, which is air inside of the trachea, and then the vertebrae, the cervical vertebrae, are showing up. Now, here is our marker. As you can see, it says PA. So this is definitely a PA film for sure, because they actually put the marker there. And then this one, don't know. But again, if they didn't really specify, then we have to say maybe it was a PA film. But then if you know you're dealing with a patient who's really sick in the ICU, they're all going to be AP films. So don't have to even worry about looking for the marker. Now, as we continue on, the mediastinum. So right there in the middle, we've already looked at the hilar, the area as far as like these are all the vessels that are supposed to be there, the lymph and etc. But so when we talk about the mediastinum in general, we're looking at the heart, the aorta, the pulmonary artery, etc., etc. So all those things are what you'd expect to find in the mediastinum. And when there's some kind of lung pathology going on, or there's some kind of lung injury, and you get things that are now shifting or pushing against the mediastinum, everything is moving. Everything is getting redirected or pushed over to either the opposite side or the affected side. Anytime that there's some kind of like CHF kind of situation, pulmonary edema, or ARDS for that matter, those lung fissures, a trained radiologist is going to be able to see these fissures regardless. But if there's a lot of fluid, then they show up very clearly in most cases. There's other little lung markings as well. There's other little like lines that are really hard to detect. Ordinarily, they call them curly lines, curly B lines, curly A lines, etc. And they go in different directions, like they go in different angles from like either the border of the lung or right from the center of the lung and etc. But just in general, when there's more fluid absorbs X-rays. So if the fluid is absorbing the X-rays, then it's going to show up on the film as white. And then if you got someone who didn't take in a deep breath before they shot the film, it might look like they have like maybe some atelectasis going on, or they just have less lung volume than they're supposed to have. And again, that'll just be instructions. You gotta have the patient take a deep breath if they can follow your instructions. If it's a ventilated patient, the X-ray technicians will look for chest movement. So they're standing there at the bedside and they're watching the chest. And so as soon as of course, the ventilator delivers a breath, toward the end of that breath, then they shoot the film. And then, of course, the trachea. Now, this is something that definitely, like with the issues that children get into a lot, where they may end up with a lot of mucus plugging because they're already small to begin with. They may end up with like a mucus plugging, or they may end up with some other kind of issue. And the way that that shows up. So if we look at the trachea for this particular film, this is dark. So this is all air. This is a trachea as we know it should be. And then I can see this looks to be the right bronchus here. And then there is the left bronchus. Now, this one looks to be kind of cut off. And the term they use is truncated. So a truncated bronchus could mean that there's mucus plugging. And look at all of this white over here. So here's air, which is normal. There's our normal hilar area, like as far as like the lymph and etc. And there's the right border of the heart. Now, all of this is very hazy, very, 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 very hazy. So where's the air? So the lung itself may not be even inflated anymore. It's probably collapsed. Now, this is not a pneumo situation. Like if you got a pneumo and the lung collapses, this will be super dark. This will be extremely black to show that there's just nothing but air out there in the pleural space and no lung tissue at all. But with all of this white and then this truncated bronchus right here, then that leads us to suspect that this has got to be mucus plugging, severe mucus plugging. Air can't get out there anymore and the lung ends up collapsing. And then once again, all this white, where is the border of the left side of the heart? Can't see it at all. It all ends up getting blurred together. Now, position of the diaphragm. So we know the diaphragm is broken into two parts. We have the right hemidiaphragm and the left hemidiaphragm. And there's two phrenic nerves. I mean, it starts off as one and it branches. So that way, each part of that phrenic nerve can innervate or connect with the hemidiaphragms. Because of our liver, the right side is always going to be a little bit higher. But when there's a problem with the diaphragm itself, then we have to take that into consideration. Like say there's a hemidiaphragm paralysis situation going on, or there's some kind of the liver's now enlarging, maybe that hepatomegaly for whatever reason, and that's causing the right side of the diaphragm to be even higher than normal. So now we take a look at this picture on the left, and here's our phrenic nerve. I mean, left, right phrenic nerve, each innervating the corresponding side of the diaphragm, and top border of the diaphragm on the right side is a little bit higher than the left side. And then we look at this X-ray here. What's going on with this patient? So I couldn't find these issues with like pediatric patients. I looked and looked and looked. So these are going to be, a lot of these films are adults, but we're just going to assume that the same thing can happen with a child. So when we look at this X-ray here, this is the right hemidiaphragm, and this is the left hemidiaphragm. So there's our marker for reference. So this is the patient's left side. So her left hemidiaphragm is way up here compared to the right hemidiaphragm. Now, the problem, it's got to be some kind of paralysis going on. If there's something going on with that left phrenic nerve, then that signal is no longer making it to the left hemidiaphragm. And when paralysis typically happens, they find a lot of cases where that side of the diaphragm will get stuck or will no longer move. It'll just be still stuck in like the up position, like when your diaphragm's at rest, like its normal dome shape. It tends to be in that position, and rarely do they find it stuck in the flattened position. But it can change. It can shift depending on, especially if you got someone on the ventilator. And then the right hemidiaphragm, it looks to be okay. And we're gonna have to say that when they had her to do this film, they told her to take in a deep breath. Taking a deep breath and hold it. So with that deep breath, the diaphragm should flatten out. And it did on this side, but on this side, I didn't do anything. It's still stuck in that resting position. I also have to comment that just looking at our general anatomy again, here is the right bronchus. Because of all this white here, it's really hard to tell where the carina is. And it's somewhere in there. I can't really detect it that clearly, but I do see what looks to be the markings of like the right, and that looks to be the left. So I'm thinking carina is maybe right there. Right border of the heart, left border, and then all of this just kind of gets blurred together. So there's a lot of silhouetting going on here. But is this maybe extra adipose tissue? It could be. It could be. That's what's causing this all this blending and blurring kind of action that's going on here. Otherwise, we say maybe that's fluid. Maybe there's a buildup of fluid in the abdominal region. And again, fluid shows up as white. And anything behind it is going to get pretty much shadowed out. Okay, now these are definitely babies here. So we're looking at two pictures that represent a baby who's intubated. And as far as the tip of the ET tube, thank goodness with babies, you don't have to try to remember, is it 2 to 3 centimeters above the diaphragm, or is it, is it 4 to 6, or is it, different authors are going to have different viewpoints on where the tip of the ET tube should be for an adult. But with babies, we say that if it's between the clavicles or slightly below the clavicles, it's in good position. So that saves you the trouble of having to try to estimate, is it the appropriate height above in centimeters. So here we have the tip of the ET tube. This is the radiopaque line. And this is the other border of the ET tube that happened to show up as well. But this for sure is the radiopaque line because it's darker, or it's more white than the border of the ET tube. And then this right here is also the ET tube that's just the part that's hanging out of the mouth that's going into the patient's airway. So then it goes and it curves inward this way. All right, so looks to be good placement. It's kind of hard to see the clavicular heads here, but we know it's in this region here. So it all looks well, and I can even see the carina. Baby films usually show up, everything usually shows up pretty clearly. They don't have that much muscle, much other tissue that's going to interfere that much. So that's the carina. And I'll come back to this one And then this right here, this white line, this is the feeding tube or the NG tube that's going all the way into the stomach. Now, this one, they've got the arrow to kind of show, whoa, look at where the tip of your ET tube is. Your clavicles are way up here, and your ET tube is way down here. Now, it could be that the baby's head position wasn't neutral, meaning like if you're not careful when you're shooting an X-ray for a baby, if their head is flexed or their neck is flexed and their chin is touching their chest, then that could make the ET tube shift. It could end up shifting downward. And then if you're not careful, if you pull the head back, then that can make the ET tube shift as well. So with the position of the baby's head, it's important. So whoever's doing the X-ray, they're going to need help usually because they can't do it all themselves. They can't operate the machine and correctly hold the baby in the right position. So that's where definitely you or the nurse will have to come in and put on your lead gown or apron and make sure that the head is centered and it's not flexed or it's not extended, because that will make the difference on where the tip of the tube ends up landing. Just remember that those little ET tubes don't have cups on them at all. So that makes the position even more variable because of just normal movement of the head from one side to the other side or the neck itself. It's going to make it move into a different position. But clearly, this one on the right is way too far down. And just looking at what I can see from the rest of the image at the top, like the head, all I can really see is that this looks to be maybe the chin. Is that the chin or is that the chin? I don't know. But either way, this could be one of those cases where you're going to have to pull the ET tube back until it's right there between the clavicles again, or right just below the clavicles. And now, because this ET tube is so far down, it is literally in the baby's right bronchus. So that is the right bronchus. I can't see exactly where the carina is, but I know that this is way down in the baby's right bronchus because this side is dark, which means air is getting to this side. But look at this side. There is no air at all being delivered. So that means this side is collapsed. And once you pull the ET tube back up, then both sides should start to get inflated again. And then just to show all of this right here, this is again the part of the ET tube that's on the outside that's just kind of hanging out there and connected to the actual ventilator tubing way over here somewhere. And then there, once again, this line right here, the straight, solid white line is the feeding tube. I can see the right border of the heart, but can't really see the left border because it ends up getting all blurred with everything else that's going on here. Lung itself isn't even inflated. Now back to this one. This poor baby has got a left pneumo. So look how it looks really dark right here in this region. And then also the lung markings aren't really that distinctive. You can kind of see maybe a little bit here, but for sure there is a pneumo going on. And then if you look even closer, this right here, this is a chest tube. So they're treating the baby for a pneumo already. But the pneumo is definitely still there because this is still a lot of air. And it even looks like there's air that's now kind of like surrounding the heart itself. So that's probably not the case. I'm not exactly sure if there's a pneumopericardium that's happening, but it could all still just be the lung itself. I mean, as far as like the pneumo that's happening in the lung, or at least on the left side here. Okay, now CVP, or central line catheter, or central venous pressure catheter. We know that when we looked at it the first time in the hemodynamics course, we said that it's acceptable to have your central catheter either sitting right above the right atrium in the superior vena cava, or just inside of the right atrium. And either way, it should be fine. So we're saying here that it should be right above the right atrium for these babies, because if it ends up going into the right atrium, it could stimulate. It could actually, the tip of the catheter could end up touching the right atrium, and then anytime you get that kind of stimulation, it's going to possibly lead to some kind of cardiac arrhythmia. So for them, it's not a good idea to advance your central catheter any farther than just the SVC above the atrium. And then we're always concerned about pneumothorax when they're inserting these catheters, and that goes for any patient. So now, what's going on with this picture here? Now, why is, oh, okay, all right. So I didn't have a picture to show a CVP catheter, but I did find a picture that shows again, a pretty bad pneumothorax. So here's a pneumothorax for sure. All this dark is just air. And this poor baby, and we'll talk about this in the next chapter, this poor baby has diaphragmatic hernia. So all of this right here that you're seeing, all the dark, kind of looks like if you took like a sock and you put a bunch of like oranges in the sock. That is intestines. So his intestines have moved from of course, the abdomen area through an opening in the diaphragm and made their way into the thoracic space. And what they did was, this is usually what you expected to do. This could be a very serious situation if you can't get the baby treated quick enough or get them to surgery. But they have a feeding tube inserted. They'll sometimes use the feeding tube as almost like a diagnostic, kind of see whether or not really this is diaphragmatic hernia. And if they did it for a diagnostic purpose, once you insert the NG tube, or the OG tube for babies, once you insert this tube into the stomach, the tip of it will be in the stomach. And look where the stomach is. The stomach is way out here somewhere, and then this is all the other intestines, the small and large intestines. So that would be a definite no-brainer that this baby has a diaphragmatic hernia. All right, now, airway obstructions. So we know that when it comes to the upper airway, if there's any swelling going on, even in the lower, well, not want to say the lower airway, but I'm just going to focus on upper airway. If there's any kind of swelling, it's going to lead to some respiratory problems. So like in the case of someone who always ends up with like a tonsil infection, and they would possibly end up having, if it's like a chronic kind of thing, they could end up with OSA, and in which case they would have to consider a tonsillectomy to deal with that problem. And then the croup, which is also swelling, is considered to be swelling right below your glottis. So if you go between your vocal cords, that region, if it starts to get narrower, if it starts to inflame or whatever the case is, then you're going to have what's, of course, known as croup. MBRC is never probably going to give you croup as just croup. If they're going to ask you to make a determination, like what do you think the patient, what should the patient be diagnosed with? So all the things that you would associate with croup, like the stridor, the barky kind of cough, and the X-ray, the steeple sign, and all these other things. If you already seen all those things, and then they're finally asking you, what should this child be diagnosed with? They're going to give you options to choose from. If you're going to be looking for a croup, you're probably not going to see croup. They're going to instead use laryngotracheal bronchitis. Why they do that, I don't know, because everyone just refers to it as croup, but the MRC just wants to, I guess, check to see if you really do know that this is what croup really is. It's like there's swelling, there's an itis going on. So laryngotracheal, broncho is the problem. Commonly, you're going to find croup with the younger kids, like anywhere from 6 months all the way up to 5 years. And it's always it's a viral thing. It's the parainfluenza virus that they isolate. That's usually the cause of it. Croup is not necessarily an emergency, life-threatening kind of situation. A lot of times you can help them at home. You can just kind of like watch them, and I've even heard some people say that you could what is it they could do? Something about the steam in the bathroom seems to help. And you think that steam would make things like you would get more swelling with steam, but you're not giving the baby steam directly or the child directly into the airway. You're just kind of like giving them a chance to breathe in what's already in the air. And then I guess that kind of helps to soothe the trachea. And then you may have to, again, just watch them carefully to make sure they don't get worse. And it will usually, the body can kind of usually take care of it. And on X-ray, they don't necessarily have to always do the lateral neck, because this image right here is our true lateral neck film technique. Or position, or whatever you want to refer to this as. Here's a standard AP. And it still shows up as the classic, like the church steeple or pencil point, some people will refer to it as. And then on this film here, it's showing up there. There's a narrowing that's taking place here. Again, this is below the cord, so it's subglottic swelling is what it is. Now, epiglottitis, this is something you don't really want to mess around with. If the child has developed what looks to be epiglottitis, you've got to get them some help quickly. So you're thinking like ER visit for sure. And because it could be so severe, and of course, the smaller the child, the more at risk that they're going to be as far as not being able to breathe. So at least with croup is a narrowing right below the cords, which means that it's hard, but they can still get air in and out, and it's just like going to be a lot of stridor that's associated with it. Now, again, epiglottitis, it's not the same organism. I mean, of course, the parainfluenza virus is what's usually behind your croup, but with epiglottitis, it's a bacterium, and the bacterium is H. influenza. You still get stridor with epiglottitis, but this is a little bit beyond that. I mean, this is kind of like you're going to expect to also not really, they're not going to be really talk. And there's going to be a lot of drooling associated with this as well, because your epiglottis, part of the swallowing reflex, when you swallow, so many things have to happen. And one of those major things that has to happen is your epiglottis has to be able to move, and it has to be able to cover your glottis so that you don't accidentally get anything into the airway. If you've got swelling in the epiglottis and it can't move, you can't swallow. And there's just like tons and tons of drooling that'll be associated with this. Now, one thing about comparing croup and epiglottitis, again, because they can kind of have some of the same kind of symptoms or say signs, but for sure, if they've got this muffled type of voice and they're not really able to swallow, they're doing a lot of drooling, and they're running a fever, because you don't typically find too many like fevers associated with viruses, but for bacteria, for sure. So then these things are kind of all add up to say that this is probably epiglottitis that the patient is experiencing. And also, once you get that X-ray and it shows the classic, like the thumb shape, then we know what we're dealing with. So this is a situation where, unlike croup, if you try to do just a standard AP film to try to detect if there's epiglottitis, it's probably not going to show up at all on the AP film, which is why you definitely have to suggest using your lateral neck film for detecting whether or not there's epiglottitis. And your best bet would be to always recommend a lateral neck for ruling out both, whether it's a croup or epiglottitis. So there's the epiglottis. It should not be this large. And because it's this large, it's not really functional anymore. It can't really move like it's supposed to. This is just supposed to be like a little thin flap. This is like thin cartilaginous tissue. And now there's that swelling that's involved. Then your patient is definitely experiencing a lot of not subglottic, but supraglottic swelling. And of course, we never ever, once you're suspecting epiglottitis, you never ever want to have your child lying in the flat position. That's just going to make matters even worse. Sometimes this may have to be an automatic. They may have to go and do a trach, because there just may not be enough time to even try to get an ET tube in place. If you already have significant swelling, you're already going to be challenged with trying to get an ET tube past that epiglottis. So you may, again, have to just go straight to a trach route. But it all depends on the severity and how soon you got your patient there for treatment. So while we're looking at this film here, notice how your nasal cannula shows up pretty clearly. So there's the part, there's like the drawstring, is it, what would you call it? The adjustment to make it the more tighter or slacker underneath the chin. And then there's the cannula itself. Don't know how old this child is, but just by looking at the overall, the features, it's clearly this is a child. Now, respiratory distress. There's many reasons why a baby will develop distress. And what a lot of people will do is they'll just kind of group things into these categories and say, now that the baby's experiencing distress, it's possibly one of these issues here that's causing it. It could be something cardiac, like your heart problems. It could be they've just developed respiratory distress syndrome, which is what used to be referred to as hyaline membrane disease, or HMD. It could be something blocking the airway, or this maybe is a meconium aspiration situation. Or did the child end up developing pneumonia? And then these surgical lesions. I mean, after surgery, if they get like corrective surgery for upper airway problems, or like like in the case of choanal atresia, or the micrognathia, or the Pierre-Robin syndrome, where they have to go in and do some facial reconstruction of the jaw. Anytime they have any of those kind of surgeries, they are at extreme risk of going into distress afterwards, and they have to be monitored very carefully and closely over the next few days. So really, there's your acronym, CHAMPS, for some of the things that you should want to kind of consider if your child all of a sudden starts to develop distress, or if it's been one of those things where they ended up in distress right after birth, literally right after they were born. Now, this will come up in the next chapter when we get into the chapter of the lung disorders, lung diseases. But right now, let's just talk about it, and then we'll talk about it again in the next chapter. TTN, which just stands for transient tachypnea of the newborn. Anything that's considered to be transient means that it doesn't stay around for long. It ends up moving on, going somewhere else. And transient tachypnea is saying that your baby is having a lot of tachypnea right now, but then maybe the next day it's gone and they're doing a whole lot better. It's almost like magical, like you're breathing almost 80 times a minute, or probably even more today, and then tomorrow you're breathing normally. You're breathing like maybe about 40 times a minute. Then what the X-ray would look like looks like there's a lot of maybe infiltrates. There could be still some leftover fluid, and this could be related to that fetal lung fluid that never got cleared away like it was supposed to have. Now, in the case of, say, a baby who was born via C-section, they're usually at the most high risk. They're at the highest risk of developing this type of problem. And we do things to try to help them out, because eventually their body should be able to absorb that fluid. Your lymphatic system is usually going to take care of that. It just takes a little bit of time. But in the meantime, what we could do is we could do like CPT and suctioning to kind of help to get things taken care of. And one other thing I wanted to, I guess, point out here is, and it'll be pointed out again, with this type of problem, you do typically see a little bit of pleural effusion as well, because that fetal lung fluid will end up making its way in the pleural space as well. So it'll be in the alveoli, but it's a thin fluid. It's not thick and viscous. It's going to be able to kind of like leak out and make its way into the pleural space, in which case you would end up with like a little small pleural effusion, maybe. So here's day one, and this is the same baby. Day one, there's definitely something going on there. It looks to be a little bit extra hazy happening here. And he's breathing really, really, really fast. Really, really fast. And then the second day, he looks so much better. So you see more dark. So fluid is gone mostly, and now you've got better aeration. And then by the third day, it'll probably be even better. So that's what we look for in TTN, that it truly is transient and it's not going to stick around. Because if it doesn't go away after about the first day or so, then that means that there's some other underlying problems that you're going to have to look into and they have to be addressed. During that time, we were just pretty much supporting this baby, giving them oxygen or CPAP and making sure that they were improving, that you were seeing signs of improvement. Okay, let's take a 10-minute break, and then we should be almost done with this chapter on x-rays, and then we can get into the actual pulmonary disorders part.